Good evening, and thank you all for joining us tonight. We appreciate you spending some time with us here on this Wednesday evening. We'd like to thank Dr. White here for joining us for the DocShop Pro webinar. A few housekeeping notes while we get set up. Everyone is muted. If you have questions, please submit them in the chat. And throughout this, we'll be sending out polls, and feel free to ask anything that comes up as we go. We'll make sure Dr. White answers all your questions at the end. Tonight's topic is remote patient monitoring, leveraging diabetic shoe fitting to keep ulceration in remission. Obviously, leading us tonight is Dr. Josh White, a very well-known face in the podiatry industry for many years. Before we let Dr. White take off and run with us, I'd first like to note, for those who aren't familiar with DocShop Pro, we are a one-stop shop marketplace platform for your practice. You can use our marketplace to cross-comparison shop, search for daily supplies, find ancillary products and capital equipment, diabetic shoes, and all the rest. And you can utilize our partnership programs. With our My Supply Manager, we can help you take the process of reordering supplies, including brand name and generics, across dozens of different vendors, manufacturers, and suppliers, and transform it into something you can do digitally with a one-stop shop platform. Almost always, we can also save you money, which in the end is always important to you. DocShop is designed to be plug and play for your workflow and for your staff, and registration is free. Cost analysis are free. We're here to be consultants for you. Our job is to save you time, money, and headache when it comes to managing your supplies, and we're here to help independent podiatrists and practitioners alike. This evening, obviously, we're joined by Dr. Josh White, a podiatrist and certified podorthist who is currently the vice president in OrthoFeet and has long combined his interests in foot care and shoes. Selected as one of the most influential podiatrists in the U.S., he created SafeStep, which offers a proprietary web-based program for streamlining shoe ordering with guaranteed assurance of Medicare compliance. Dr. White serves on the American Podiatric Medical Association committee that addresses matters relating to DME. He's a coding line expert panelist, and he is very recently, and congratulations, Dr. White, a new board member for the American Academy of Podiatric Practice Management. On the side, he somehow finds time to be an Ironman, and he has completed 3 Ironman and triathlon events. That's impressive. We're obviously honored to have you here, Dr. White. We always love to hear you speak. With that, the floor is yours. We'll be taking questions throughout, and thank you all again for making time for us.
Nick, good evening. Thank you. And thank you, everybody, for joining. And very glad to be able to share with you some ideas about how to improve the care of your patient's feet, and how that can be very much improved by combining the therapeutic benefits of therapeutic footwear and leveraging improving patient compliance with a new Medicare initiative known as remote patient monitoring. So I will be sharing with you a little bit of generic information about what remote patient monitoring is, how it can be used by podiatrists, and how it specifically applies to the care of patients with diabetes. Remote patient monitoring has received increased attention during COVID, as patients were not able to visit their doctors, and so it falls under it falls under the broader concept of telemedicine, which is the idea of a patient being able to receive care without being face to face in the same place, without being in the same place with their physician. Remote patient monitoring generically refers to keeping tabs of something about the patient, with that information being able to be monitored or read by someone somewhere else. And there has become a mainstreaming of this concept with the advent of such consumer products as the Apple Watch and pedometers, and the idea of people suddenly becoming, having information about themselves, whether it be heart rate monitors, available, just with regards to becoming a blurring of information that people are interested in monitoring on a regular basis for their general health, and as opposed to what has been most commonly utilized in the past. People say people with diabetes using a glucometer to measure their blood glucose, or people having to take their blood pressure, monitoring it and reading that information themselves. So a number of factors have converged to make remote patient monitoring increasingly popular, and that relates to an overburdening of the healthcare system. So this is a way of instead of having the patient having to come into the clinic and see someone to simply have their, say for instance, have their blood pressure taken, this can now be done from the patient's home, and as accurately. The technology that allows this type of monitoring of communication has become more accurate, has become easier to use, and has become less expensive. There has been adaptation by payers of this kind of technology, such that the reimbursement models that they offer make it worthwhile for the provider to say to the patient, it's okay, don't come into the office. In effect, I'm okay with giving up the reimbursement available from a patient visit, because I can get paid by getting that information in a remote manner. Another sort of another term or a change recently in the Medicare program relates to what's referred to as general versus direct supervision. So not too long ago, when remote patient monitoring first emerged, it required the physician, him or herself, to follow up with the patient directly. That's what's referred to as direct, so or the patient, the doctor, him or herself, or someone in the doctor's presence. Now, general supervision refers to that work able to be delegated to someone or even to a service that does not need to be in the presence of the doctor, but simply working under the doctor's supervision, and responsible to the doctor, but again, does not need to be in the presence of the doctor. So that's a big difference and has made a lot of change possible. And finally, there's a growing patient pool, a growing number of people over 60 who have chronic conditions that would benefit by being monitored, such that you see here that the over 60 population, again, is doubling from 2015, nearly doubling from 2015 to 2050. So remote patient monitoring means monitoring a chronic condition, and the Medicare program does not even specifically say what those chronic condition, what that chronic condition needs to be, but some examples could include such things as diabetes and prediabetes, hypertension, obesity, and COPD. And the type of device or the physiologic measure related to those would be measuring blood glucose for people with diabetes, blood pressure, measuring weight, the weight of people who are obese, and pulse oximetry for people with COPD. The devices that would be used for the monitoring, the remote monitoring, would be a blood glucose monitor, could be a blood pressure cuff, just a scale, or a pulse oximetry finger monitor. Now, any one of these devices is not just your old-fashioned blood glucose monitor device. What makes these new types of devices special are their ability to store the readings that they take, and then and have a mechanism for communicating that information, that daily measure, eventually to the cloud, eventually getting it from the device to the computer so that it can be read by the doctor. Okay, so that's the gist of what makes for a remote patient monitoring device. Okay, and that's what makes it different from just a regular old blood pressure monitor. Medicare's remote patient monitoring program entails both the transmission of daily readings, as well as, and requires, monthly communication from the physician's office to the patient, to give them some direction, some feedback, some ideas with regards to patient care, as a result of that monitoring. That communication might be, keep it up, everything looks good. It might be, it looks like you put on a couple of pounds. Let's talk about why that's happening and what you could do about that. And so any office that is taking on a remote patient monitoring program will have to figure out whether it makes sense for them to do it themselves, do it yourself, DIY, meaning have someone in the office have the responsibility of reading the information and interpreting it and following up with patients, as is required by Medicare, to receive reimbursement, or whether to outsource that requirement, that process, to a service. Either way can work, provided it's set up and followed appropriately. And so, just the process flow, the way remote patient monitoring works is that the patient who has a chronic condition would be given a remote patient monitoring device. The patient is provided with some type of means for getting the feedback on what's going on. And so companies can provide, sometimes it's an app. Sometimes it's an app that they can download onto their own smartphone. Sometimes there's a digital device specifically designed to pair with and work with the patient device, and to provide information about the physiologic condition being monitored. That information not only goes to the patient device, but would be communicated, uploaded to the cloud, which means that information then from the internet could be accessed in a HIPAA compliant way, a secure way, to be able to be read, also by the physician, or the physician's assistant who is monitoring the patient's condition, and provide the required monthly follow-up. Okay, so again, this is generic. This flow is generic for the condition, for the device, for the means of communication. Okay, and so this is just to give a general concept of the way remote patient monitoring is supposed to work. So let's speak a little bit about diabetes and why remote patient monitoring makes so much sense to improve the care of patients at risk for foot ulceration. And so with that increase in the aging of the increase of the geriatric population is a concomitant, even greater increase in the incidence of diabetes. And so the problem that has been big for a long time is getting much, much bigger. And Medicare analysts who are looking at where the money is going and what can be done to reduce the cost of healthcare are very much aware of and interested in doing something to reduce the incidence of these ulcerations, because again, the patient pool that is at risk is large and growing, and that in fact, and that when these problems occur, they are very expensive. So, so about 1 in 20 people with diabetes, Medicare beneficiaries with diabetes, and again, Medicare recognizes that pretty soon, because of the growing number of people with diabetes and the rate of obesity, very soon the percentage of people with pre-diabetes is predicted to be more than 50% of all people 65 and over. So, there's a big round now. There's a lot of numbers related to the incidence of to the cost of diabetes, but the cost of the treatment of an ulceration. But I like to just, citing different studies will relate to make for different dollar amounts. But I like to think about $15,000 as being a ballpark number that could make sense. Once a patient has developed an ulcer, there is a nearly 50% rate of that ulcer that has healed to recur within 1 year. So think about that. Patients who have gone through a wound healing process might have taken weeks to months, and $15,000 or more being spent on that ulcer has a nearly 50% chance of that wound recurring within a year. And even more significant is that 1 in 20 chance of that patient who had required who had a diabetic foot ulceration will require a major amputation within a year. That means not just a toe. There's a 1 in 20 chance of mortality, 1 in 20 chance of the patient who had a ulcer dying within the first year, and a nearly 50% chance of them dying within 5 years. That that's one study. Here is another study that showed greater than 50%. And to put that into perspective, that likelihood, a chance of dying within 5 years is worse than what's associated with many common cancers. So again, it's just to put into perspective the significance of I like, as David Armstrong refers to, keeping healed ulcers in remission, and adopting the attitude that once a patient has developed a wound, and recognize that only 2 out of 3 people with diabetes will not develop a wound in their lifetime. 1 in 3 will. 1 in 3 will. So there is somewhat of a sense of denial among many patients that they are not. It's kind of like COVID. Oh, I'm not going to get it. It's not a big risk. And to a certain extent, that's true. 1 in 3 will develop. 1 in 3 people with diabetes overall will develop it. And understand, of course, there are patients with greater risk factors who have a greater risk of developing that. So just like in COVID, there are higher risk populations. But overall, 1 in 3 people with diabetes will develop an ulcer. 2/3 will not. But of those patients who have developed an ulcer, who are by definition at significantly increased rate of developing another ulcer. And so these are the people that we need to focus on, and I think it would be very helpful to perpetuate that concept of keeping that ulceration in remission. They continue to be at risk, and this is where diabetic shoes and remote patient monitoring become so important. And so it's clearly understood that diabetic foot ulceration is very much related to plantar foot pressure, and that the more pressure there is on the bottom of the feet, and the more steps that are taken, the greater the injury, or the greater the damage that can be done, the greater the chance of ulceration. And so being able to keep tabs on the pressure on the bottom of the foot and how much and how long that pressure is being exerted on the bottom of the foot can be very significant in terms of detecting how much trauma is being exerted. Now, very significantly, it's been recognized that ulceration is an inflammatory process, and that as such, prior to the skin breaking down, prior to ulceration occurring, there is an increase in skin temperature. Okay, and so it's been recognized that a sustained temperature increase of greater than 2.2 degrees Celsius when comparing one foot to the other is a significant and reliable predictor of pending ulceration. And so being able to combining that ability to measure pressure and step count combined with a ability to monitor foot temperature can be quite effective at helping to regulate what's going on with the feet and to understand when an ulcer is has a good chance of occurring, and most importantly, being able to intervene to do something to relieve that pressure before the skin actually breaks down. So again, we talk about measuring pressure. And again, it's not just the pressure as a snapshot, it's the pressure over time, or how long the pressure has been high pressure has been sustained, are the significant factors that contribute to the skin breaking down. And being able to monitor how many steps the patient is taking is key to being able to literally be able to prescribe to the patient how much walking, how many steps might be the safe zone for the patient to be able to stay in, such that they will be able to avoid that inflammatory process and seeing the increase in temperature that can result from the skin being damaged and ulceration potentially developing. So thermography is not new. It relates to being able to measure skin temperature, and again, that science that relates increased skin temperature to diabetic foot ulceration and recurrence has been around for some time, and is well studied by Lavery and Armstrong and there have been devices that many of you are familiar with. This one called the Temp Touch that was out there, and it worked. But the idea was that it had to be used by the patient to measure, touch their foot and measure their temperature and compare one foot to the other. And but it really didn't work very well in a practical sense, in that these devices were expensive and it required the patient to do something every day. And so as a result, it didn't really change the world. Okay, so a good idea, a good concept, but it worked for some people, but it has not worked with enough people to really make a difference in terms of diabetic reulceration. It did not work to keep ulceration in remission. Fast forward to the present, and with the combination of those factors that I referred to earlier with regards to Medicare reimbursement and with regards to improved technology and with regards to, learning. It's like Elon Musk, keep blowing up rockets and learning how to make things better. There have now emerged that I'm aware of. Well, I'll say there are two companies that I'm aware of that are now focused on providing products to physicians and their patients to help reduce diabetic ulceration. And those two products, those two companies are Siren sock, Siren, which make a type of remote patient monitoring enabled sock, and Orpyx, which makes a remote patient monitoring enabled custom insole. Okay, so two different devices, that have, there are similarities and there are some differences to their approach. And so I'm going to share with you my understanding of how they work and some of the strengths and weaknesses. And again, I work with OrthoFeet. I don't work for Siren. I don't work for Orpyx. OrthoFeet is a distributor of Orpyx insoles, meaning that you can buy Orpyx insoles through OrthoFeet. But the message that I want to communicate through this is that I think is that in general, remote patient monitoring offers tremendous promise to improve the therapeutic efficacy of diabetic footwear by being able to provide feedback to patients and to physicians, and to improve patient compliance with regards to initiating or utilizing good behavior in terms of checking their feet and ensuring that they have the protection that they need in order to keep their feet safe while being active, because it's certainly possible to reduce plantar pressure by reduce plantar pressure by keeping your feet up and not walking. And that's not at all the desire. The goal is for patients to be able to walk as much as possible to maintain their mobility and independence and health, but do so in a way that is not going to cause damage to the skin. So both of these types of devices, both of these products, again, have the monitoring device, the Siren sock or the Orpyx insole, and both of these companies provide the patient with have a digital device. So again, Orpyx provides a cellular device that looks like a smartphone, and the Siren works with the patient's smartphone. Now, what I am advocating is that practitioners follow a very commonly recognized approach to care, and that is that every patient with diabetes should have an annual ulcerative risk assessment exam, at least annually, and patients who are at higher risk should be evaluated with regards to their neurovascular status, structural changes, and dermatological status at least once a year, and for patients at highest risk, as much as quarterly. Okay, so patients need to be evaluated to see if there are any changes, if any neuropathy has developed, if the circulation has gotten worse, if there's a new structural change, and based on that evaluation, appropriate care prescribed. So appropriate care for patients with ulcerative risk factors should include socks. It should include prefabricated or custom diabetic insoles, and should include appropriately fit but professionally fit therapeutic footwear. And what I'm advocating for, recommending, is that in addition to prescribing therapeutic footwear for patients who are at risk, to recognize and to utilize a remote patient monitoring device. And this is just an example of how on the OrthoFeet web-based ordering system, there's the opportunity to be able to order custom Orpyx custom RPM insoles together with together with your OrthoFeet diabetic shoes. So it's the only way where you can combine the ordering such that you can receive the shipment of the shoes and the inserts together. It's possible to order shoes from any company and the Orpyx insoles from Orpyx directly, but the products will come separately. Okay, so again, recognize that every patient in the practice with diabetes should have at least annual ulcerative risk assessment, sometimes referred to as comprehensive diabetic foot exam. Those patients should be prescribed diabetic shoes, therapeutic insoles, prefabricated or custom, diabetic socks, and in particular for those patients at highest risk for ulceration, those people who have had an ulcer in the past, emphasize to the patient the importance of remote patient monitoring so that you can improve the chances of keeping that ulceration that they had in remission, so that they don't become one of the 50% who develop a wound again within the year. So again, patients, in order for prevention to work, patients need to become more engaged, more responsible for their own care, and need to become receptive to what's going on with their feet. These devices will provide them with information about wearing time, and also tell them about how much they're not wearing the devices, and will share with them the temperature of their feet. So just like people have become motivated and engaged by number of step count, and you can just have it on your smartphone, or your heart rate, or how long you're sleeping, all sorts of things like Apple Watches can provide. People with particular patients with a history of ulceration need to become engaged, and this is a message that needs to be communicated in order to be effective from the physician, from family members, from the associates in the practice. I gave a lecture last month about nudge theory, about the importance of providing gentle, regular, and persuasive reminders on an ongoing basis in order to effect behavioral change. So information, again, is communicated from the device to the patient via digital device. Information is also shared with the physician such that it can be accessed and share with the physician the steps taken and the plantar pressure and the foot temperature. Again, that's for the Orpyx type device. And the Siren socks has similar types of readings. Communicate now the Medicare program. Medicare reimburses the physician for patients who are participating in remote patient monitoring if the physician's office spends a minimum of 20 minutes, a combination of analyzing the data and providing interactive communication with the patient. So again, 20 minutes is the requirement for billing time. More time spent can, if necessary, allow billing for even greater amounts. But the 20 minutes would entail the physician analyzing the data about the foot temperature and the steps taken, and based on how that information looks, sharing with the patient again, whether it be email, or whether it be by phone, or whether it be usually through the digital device, how they're doing, whether there's increased temperature, whether they're at risk for ulceration, whether some type of change and whether some type of change in behavior is indicated. So so each of these companies, and I would encourage becoming familiar with both of them, because every patients will have preferences, and there are patients who are at risk who could benefit from an RPM device, who would prefer to be utilizing a sock, and there's others who would prefer not having to wear a specific sock and would prefer to be wearing a remote patient monitoring enabled insole in their diabetic shoes. There are also differences in the software, the way the displays of each of these companies work for the physician, in terms of how they organize the information, how easily they make it for the physician to follow up with the patient, as well as the services available for the physician to outsource, to delegate that communication, so that the physician, him or herself, doesn't even have to do it. But so some of that information that is so important that would be communicated to the patient is how much the patient is wearing the device per day, and it's possible to see things on a trend. So if the patient has this device and is only wearing it 1 hour a day, that's not going to be doing a lot of good. Okay, so that would be information that would be necessary to be read and communicated to the patient. In addition to how long the devices are being worn, also what can be read is how many steps the patient is taking. And again, that can be useful both in terms of promoting exercise as well as ensuring that the patient is wearing the device while they're taking their steps. So they're both important. Pressure. There are sensors on the bottom of the foot of the Orpyx that can detect pressure on the different sections of the foot and can detect whether that pressure exceeds what is determined to be a concentration that can result in skin breakdown, and how long that area of the foot is in that high pressure state. When the device determines that there is prolonged increased pressure under a part of the foot, it will send a device to the patient via their digital device. The first thing is a notification will go to the patient and says, hey, the equivalent of a redness underneath the big toe or underneath the first metatarsal. The alert to the patient's phone says, we're detecting increased pressure, and take a look at your foot. It's probably might be a good idea to do something. Take a look. Maybe there's a pebble inside the shoe. Maybe there's a wrinkle in the sock. Maybe the insole has worn out and need a replacement. But take a look at the foot. See if there are any obvious changes indicating consistent with that increased pressure. And again, correlate that with temperature feedback. Again, if the temperature is detected to be greater than if there is determined to be greater than a 2.2 degree Celsius difference between the same area on one foot or the other, that falls outside of the gray zone, and that could be indicating, that could be an indication, if prolonged, of that inflammatory preulcerative type event. So the types of alerts, and this is where behavioral change is complicated. This is all about providing notification to the patient when this is like COVID testing. We don't want to provide too many false positives saying that there's a problem when there really isn't. And at the same time, we want to make sure that the patient is notified. We don't miss notifying the patient if the device actually detects something problematic occurring. So some of the notifications that are programmed to go to the patient include if the patient has not been reporting measures for 3 consecutive days. Okay, it means that they may becoming non-compliant. It's also important that the patient not just wears the device, but they not just wears the sock or the insole, but that they check their digital device to see what the information that's being reported is. It doesn't do any good if the patient is not seeing what's going on. So there will be notification if the patient is not checking the device on at least if the patient is not being reviewed prior to the end of the month. It's also a notification when there's that increased temperature, 2.2 degrees, or if there is temperature one day and is missing the next. And then if the patient has experienced 40% time in the pressure alert condition. So again, how much of the day are they spending in the high pressure? So if there's high pressure for just a short duration of time, that's not too concerning. But if there is 40% or more time spent high pressure, that's a problem. Alert goes to the patient to take a look at the bottom of the feet. So In order for the patient to participate in remote patient monitoring, they need to opt in. This is not something that they have to do. This is something that, as the physician, you have to educate the patient about and get their buy-in. They have to be compliant. They have to be willing to use the device. They have to be willing to check their data. They have to be willing to hear from your office on a monthly basis to get information about how their feet are doing. So the bottom line is they have to want to engage in the process in order to keep their feet from developing wounds. And we all know that there are patients who are highly motivated and interested in doing all that they can, and there are unfortunately way too many patients who you will have a very hard time getting to buy into the program and want to participate. And so it's important to not spin your wheels and do too much to try to enroll a patient if there isn't that kind of interest, that buy-in for them. So patients need to be savvy enough to be able to work with the digital device in order to read the data. And you need to understand, well, you need to decide whether it makes more sense, how to work with the services that are available to do the monthly patient follow-up. Essentially, the most important thing for the physician to do is to prescribe the device, whether it's the sock or the insole, to the appropriate patients, and then let the services take over from there. So Medicare provides reimbursement for remote patient monitoring, and these amounts can vary by state. But to give an idea of the type of payments that Medicare makes available, there's a one-time payment of $21 for training the patient and providing the device to the patient the first time. And then on a monthly basis, Medicare allows you to bill one code 99454 for the transmission of the information. This is the equivalent of your cable television bill. Okay, so about $69 depending on the state for that, and then on a monthly basis provides reimbursement for that 20 minutes of clinical staff time performing interactive communication with the patient or their caregiver during the month. So one reimbursed on a monthly basis. There's reimbursement for the cable bill, the transmission of the data. This is what's provided by the remote patient monitoring company, whether it be Orpyx or Siren, and a second reimbursement, 99457, for the communication with the patient, 20 minutes or more on a monthly basis, using one of the supportive services. Orpyx partners with a company called NavCare. Siren provides that service in-house. So they both work similarly. They both offload that responsibility from your office. And so recognize that this reimbursement, approximately $122, depending on the state, is available to you on a monthly basis forever, provided the patient is continuing to utilize the device and information is being communicated. So think about it. $122 per month per patient is available to you, to patients who are at greatest risk for ulceration, who can benefit from this. So just to give put some numbers to what's available to you to onboard patients. I just threw some numbers together. So the net revenue when fitting diabetic shoes with free pair of prefabricated inserts is in the neighborhood of $224. Again, that Medicare on the fine print, you see that Medicare 2021 allowable for shoes and prefabricated inserts is $329. So offices, doctors who don't think that diabetic shoes pays enough, I think that they're wrong. The net revenue from shoes, $224. The net revenue from 12 months of remote patient monitoring, while Medicare allows $122 per month, the net revenue I present here is $438. And again, that RPM annual net revenue assumes a $75 monthly service and communication cost, whether it's from Siren or from Orpyx. That's not exact, but it's in the ballpark. So 122 minus the 75, and that's 12 months. And I also assume in that calculation that not every patient is going to be, that you on board is going to be wearing the device for 12 months. I put in a 25-cent attrition factor there, so that 1 out of the 4 patients who you onboard is not going to make it. So again, the revenue per patient. So the combining of these two, or adding remote patient monitoring to your diabetic shoe fitting, can increase your revenue from $224 per patient to $662 per patient. So again, you more than double the amount that you can make, really more, and nearly triple, while providing better patient care and while improving the likelihood that your patient will remain compliant with wearing their diabetic shoes. So if the practice were to identify and prescribe and fit diabetic shoes and remote patient monitoring for 3 patients per week. So again, think about spending 3-5 hours per week. That can result in over $100,000 in net revenue. Orpyx works similarly, but a little bit different. Orpyx, when to prescribe Orpyx, you would prescribe 1 pair of depth shoes and 1 pair of Orpyx depth insole, custom insoles. The net revenue, again, is the same. From the remote patient monitoring is $438. The total revenue per patient in this case would be $551, resulting again in a very healthy, if you simply adopt a routine of fitting 3 patients per week, of being able to add over $80,000 to the practice. The key to being able to get this kind of benefit and add this kind of revenue to the practice is consistency. And you don't start fitting 3 people per week from zero. You start and you get patients, fit year after year after year. So patients who are fit with shoes should be refit the next year, and fitting them, particularly the ones who have developed an ulcer in the past, are going to be much greater risk, and should be your target market for focusing on the patients who should be provided with a remote patient monitoring device. So just a little bit of a recap of who does what to make your program successful. The podiatrist has the responsibility for performing the comprehensive diabetic foot exam on all patients with diabetes, should be the one who prescribes shoes, should prescribe a remote patient monitoring device, particularly when, and again, this is not a requirement, but I think you're going to have a much higher success of patient adoption and engagement for those patients in particular with a history of ulceration. The podiatrist is in charge of supervising the dispensing of the shoes and insoles. The podiatrist should not be doing it him or herself. There should be a fitter in the practice. And the podiatrist provides general supervision of the monthly remote patient monitoring, 20 minutes or more, okay, provided by the Siren company or NavCare in collaboration with Orpyx. The fitting person in the practice is the one who selects the shoes that are therapeutically appropriate and aesthetically acceptable. I use the expression, the 4 S's of shoe fitting. The fitter should take into consideration size, shape, stability, and style to find the right shoe that the patient wants to and will wear. The fitting person can provide the remote patient monitoring device. The fitting person has responsibility for procuring and collecting and reviewing the Medicare compliance documentation based on the comprehensive diabetic foot exam, and dispenses the shoes and the insoles. Remote patient monitoring communication, again, requires 20 minutes review of patient's foot temperature, plantar pressure, and steps, and it provides the interactive communication. This need not be performed by the practice itself. Again, Siren will provide it. Orpyx works in collaboration with Navcare to provide it. Pitfalls to avoid. Practices that are not following the routine as recommended by the APMA and the Diabetes Association, performing a CDFE on every patient with diabetes every year. It's important that the practice understands Medicare rules and requirements for shoes and for RPM. It's not that complicated, okay? Failure to get adequately trained on patient onboarding. You need to become good at encouraging good behavior. You need to engage the patients. They need to understand the value proposition of shoes and RPM at maintaining their mobility. It's not just about getting shoes, it's about maintaining quality of life and fitness. The patient must opt in for RPM. If they're not committed to the program, if they are a naysayer, if they are non-compliant, don't force it, because it's just not going to work. It's too much invested in getting things onboarded to make it worth your while. And it is very important that there is a point person in the practice, not the doctor, who's is responsible for ensuring patient compliance with shoe wearing and the RPM and the diabetic Medicare compliance documentation. So, you know, there are a lot of winds blowing at our back, helping this approach to care to be successful. And Medicare has made it clear that they, and you know, this bar chart shows how much Medicare is expected to be spending. And you see that 2021, 738 million, and in 2028, 1260. Okay, it's almost doubling. It's almost doubling, you know, in the next 7 years. Medicare recognizes the importance of investing in technology. Medicare recognizes the importance of investing in prevention. As podiatrists, we have we play a critical role in addressing expensive preventative care. I just thought that one other point, I thought that this headline really caught my eye, just to add to the need or the demand for our services, and it related to how much weight people have gained over COVID. 2 pounds per month. Okay, 2 pounds per month. So it's more important than ever that your patients be motivated to participate in a walking program. CDC says 15 minutes of moderate exercise per day. Their feet need to be protected for them to engage in this type of approach lifestyle. So to wrap things up, recognition of increased foot temperature and increased plantar pressure are related to, understood to be early indicators of impending ulceration. SMART, this relates to technology imbued. Shoes and socks and insoles offer an opportunity to monitor these predictive factors and provide, allow for early intervention to reduce the likelihood of ulceration. Advances in the technology, changes in reimbursement models, and offer the opportunity for podiatrists to improve the care of their patients and to make more money and to improve patients' quality of life. With that, I would be happy to take any questions. Thank you.
Thank you, Josh. We had a couple questions here. So I'm going to go ahead and read them off to you. The first was, if high pressure is identified, but temperature increase is not seen, does that alert qualify as a reimbursable RPM billing since it's not a physiological element?
Yeah, it is the temperature. It is the temperature, and again, this is cumulatively. So, just monitoring temperature. Just because the temperature does not have to be increased in order to qualify for reimbursement, but yes, just measuring pressure is not in itself is not a physiological measure that I do not believe qualifies as a qualifies for Medicare reimbursement. But measuring for temperature, whether or not in combination with pressure, is. And again, if you have the risk for ulceration, it doesn't mean that the temperature has to increase to qualify for reimbursement. You simply have to be monitoring it, and if the pressure is, if the temperature is not increased, that's a good thing, okay, and is reimbursable.
Perfect. And if that didn't answer your question, Dr. Cantro, please let us know. Another question came in. Do you have a sample of written consent to use?
For remote patient monitoring?
Yes, for the written consent portion.
No, that would be best obtained from either of the two different companies.
Okay, so Orpyx or Siren would provide that, though?
Yeah.
Yeah.
Because that's who the provider subscribes with.
Okay. And then can you speak on the controversy on being able to bill for DME and for remote patient monitoring for the same patient, since SOCs are not reimbursed by CMS? So essentially, who would pay for the DME bill or the SOC bill? I believe was Dr. Ong's question.
The device, whether it be a blood pressure monitor or pulse oximetry, or a foot temperature sensor, is to be provided to the patient at no cost to the patient, and the physician, can reimburse that $21 onboarding. So that's one. So the device, no matter what it is not to the patient, is not expected or is not allowed to be charged for the device. The physician gets reimbursed for the providing of the device, meaning the training on the device, and then gets reimbursed for the monthly communication and the receiving of the data. That's completely separate and independent and has nothing to do with reimbursement associated with the Medicare therapeutic shoe program. So by providing shoes, by providing insoles, having nothing to do with sensors, whether it has nothing to do with sensors, those items are reimbursable. So again, if the provider is to be paid for by the device, it's only because they have billed for that device under the diabetic shoe program. And if they are to be paid for the cost, their cost for the sensor, whatever it is, the monitor is made up by them in what they make each month. And that's why it's so important that if a patient is only on board, is only using the device for 2 months, and the doctor is only getting $122 times 2, the doctor may take a bath because they have given a device to the patient that they have not been able to recoup the cost on.
Perfect. I think that answered that question. And the last question I'm showing right now was, you mentioned the 20 minutes of consultation and that either Orpyx or Siren would provide that. But is that 20 minutes a week or 20 minutes a month for the patient?
A month. And it's cumulative, and it doesn't have to be communicate. It's interactive. It's interactive communication. So it includes time that the clinician, and again, not the doctor, him or herself, but the you might say outsourced or delegated to, but supervised provider of that care, spends analyzing, looking at the data, and communicating with the patient, whether it be by email or whether it be by through the digital, some kind of like FaceTime-ish, but HIPAA compliant, and Although that was, I'm not sure if that's still in place or not with COVID, but it's a combined amount of time that is documented by, but self-reported with each of those companies.
Perfect. Well, I believe that is all of our questions for this evening. So I wanted to thank you so much, Dr. White, for your time and your insight. I wanted to thank all the attendees for carving out part of their evening and joining us. We truly appreciate it. We will be posting a replay of this, and we'll also have it available on our YouTube channel if you want to check back for notes in the future. If you have questions, certainly Josh is available for follow-up, as is the Doc Shop Pro team. We can't thank you enough. Be safe, have a great night, and take care. We'll see you next time.
Thank you. Good night.